All right. Hello, everyone. I am Sunil, Dr. Sunil Rathore. Thank you for joining Headache School, brought to you by the University of Utah, the Department of Neurology, Division of Headache. I am a headache fellow here at the University of Utah. And happy belated National Infertility Awareness Week. This was just last week. My talk is partly inspired by my family. On the left is my wife, Priyanka, and on the right is my 4-year-old son, Dave. Um, just last year, my wife asked me if I thought we, could expand our family. You know, I, kind of said, sure. You know, we're not young by any means. We've dedicated most of our lives to advancing our career and taking care of patients. And so at this point, a year has gone by since I said sure. And it's become obvious to us that we probably should look towards assisted reproductive technology or ART, and namely in vitro fertilization or IVF. And so, as a headache specialist, I started to be curious about how IVF may affect headache, namely migraine. And in that regard, how does IVF affect, migraine? How is this pertinent to this channel, to Headache School? So a couple of facts on that. During childbearing age, migraine is at its most prevalent, affecting a quarter of women between the ages of 30 to 39, according to the American Migraine Prevalence and Prevention Study. And infertility is a common condition estimated to impact 1 in 7 couples in the developed world, such as the United States. The rate of assisted reproductive technologies, or ART procedures, performed in the US, according to the Center for Disease Control, or the CDC, is increasing. So, for example, in 2007, assisted reproductive technologies, or ART, was just at 150,000 cycles per year in 2007. If you look at 2016, that tripled to 250,000 cycles. And then in 2023, that nearly doubled to just under 500,000. So the use of ART is quickly increasing every year. It's not going away. It's becoming more and more prevalent. Another fact to consider is that almost a quarter of women with migraine report avoid becoming pregnant because of their migraine diagnosis. In the Chronic Migraine Epidemiology and Outcomes Study, or CAMEO, some patients report choosing not to have children or delay having children because of their migraine. Now, this is due to a variety of factors, partly because patients are burdened by, having chronic pain such as migraine, and also because some of the preventative migraine medications are unsafe to continue during pregnancy, and this further delays women deciding to become pregnant. Another reason this could be the case is because the cost of migraine is quite burdensome. It's estimated that the direct cost of migraine is anywhere between 500 to about $7,000 per year. And this doesn't include the indirect costs, such as missing out on work, which is almost $5,000 per year. Accessing assisted reproductive technology is also costly. Um, so fresh transfers of IVF is almost $13,000. That's with insurance. And frozen transfers are about $3,000 per year. So if you add up these two costs, migraine and assisted reproductive technologies, it's conceivable that the combined cost is simply out of reach for most people. Now, before we get into the impacts of IVF on migraine, we probably should get into some of the basics of IVF. Now, I will say that I'm not gonna take up too much time during this talk in getting to the details of IVF. Some of you who are joining this talk, you may have already decided to look into IVF, and congratulations to you. I will leave that between you and your reproductive endocrinologist to get into those details. I'm a headache specialist. I'm not a reproductive endocrinologist, so I will claim some modesty on that. We'll cover only the basics on it. But in order to get into the impacts of this, we should probably discuss some of the basics. So the basics are that there are the typical IVF cycle phases, which include the hypothalamic pituitary ovarian axis downregulation, or the HPO axis downregulation. This is often done with GnRH modulators. There is ovarian stimulation, egg retrieval, embryo implantation, or in the case of those that are not doing immediate family planning, cryopreservation. And it's important to understand that differences in IVF medications and differences in IVF protocols can influence the levels in estrogens. And the differences in the estrogen levels can have an impact in the patient's headache frequency and/or severity. And zooming out on IVF, these are kind of the basic steps that occur. Ovarian stimulation leads to increased estrogen and follicular growth. Oocyte maturation is the next step, and ovulation. The egg is then retrieved using transvaginal ultrasound. Eggs are then fertilized, and a fresh embryo is transferred to the uterus, and pregnancy confirmation takes place. Slash, if again, the patient is not expecting to do immediate family planning, cryopreservation. Now, again, the most relevant thing to us is headache impact. So if a pregnancy doesn't happen, or if embryos are frozen instead of transferred, the patient's hormone levels, especially estrogens, can drop quickly. And that drop in estrogen is the most relevant piece of information. Now, aside from IVF, there's another relevant sort of hormonal uh, change that happens in a woman's body outside of IVF, and that's just during menstruation. So during a normal cycle, estrogen levels can rise and fall. Around ovulation, levels are usually around 200 to 500 picograms per milliliter. During a woman's period, they drop to around 20 to 50 picograms per milliliter. So this spectrum of estrogen can vary between 20 to 50 to 200 to 500. And I'd like you to keep that in mind, because in the next slide, I'll talk about that spectrum of estrogen that occurs in IVF. So during IVF, hormonal levels can change much more than in a normal cycle. Some medications in IVF lower estrogen to below 20 picograms per milliliter. Others raise it as high as around 3,000 picograms per milliliter. This means that hormone swings during IVF are much larger than what a woman's body usually experiences. So I'm going to go back to that previous slide where we looked at estrogen levels during just normal menstruation. But before I do that, I'll reiterate, during IVF, that spectrum of estrogen ranges from 20 to 3,000. And we'll go back to the previous slide. And in menstruation, estrogen can range from 20 to 500. So 20 to 500 in menstruation, and in IVF, 20 to 3,000. And going back again, in menstruation, 20 to 500. And it's that drop in menstruation from 500 to 20 where peak headache occurs in menstruation. And then in IVF, from 3,000 to 20, where that peak headache occurs. So the profound amount of headache that can occur, the potential for headache is much higher in IVF, that drop in headache, that drop in estrogen that can occur, and the peak amount of headache that can occur in IVF. Now I put a picture of myself both right side up and right side down because this is how I felt when I encountered a patient in the clinic post IVF, and a successful IVF at that. The patient came to me after already going through IVF and having successfully had a pregnancy and a normal, healthy baby, thankfully. Quite happy about that. But she explained to me, her and her husband explained to me that she had experienced pretty profound headaches during the HBO axis downregulation, that hypothalamic pituitary axis downregulation, because that's when estrogens are driven up quite high and then quickly driven down very low. And that's when she experienced the great peak of headaches. And I saw in her chart that those very high levels of estrogen and the nadir of estrogen levels too. And so I really wish that her reproductive endocrinologist knew about our headache division and had coordinated with us beforehand because we could have come up with a good game plan knowing that estrogens would have dropped and we could have really coordinated a good game plan for that expected drop in estrogens so that she had a more comfortable IVF program. And I'm glad that she had a baby, but it could have been more comfortable. All right. So again, let's back up for a second. Let's look at menstruation because we do see kind of a mirror of estrogen and headache in menstruation. So drop in estrogens in the luteal phase of menstrual cycle is a trigger for menstrual migraine. And so we'll just look at the luteal phase. So we can see the estrogen levels just kind of drop over here. The hormone levels, the estrogen and progesterone, and the lining of the uterus change throughout the cycle. Each month, the uterine lining thickens to prepare for a possible pregnancy. If a pregnancy doesn't happen, hormone levels drop and the lining sheds. This is, the period. For some people, migraines are triggered when estrogen levels drop. This drop happens right before and during the first few days of the period. This is when a migraine risk is highest for people with menstrual migraines. So back to IVF. Because IVF treatment causes drops in circulating estrogens during the HPO axis or the hypothalamic ovarian axis downregulation, it predisposes people with migraines to have worsened headaches. Right. So we'll go into, some of the different treatments, the medications that are used during IVF. So one of those are estrogens and selective estrogen receptor modulators, and the different risk involved. So this first statement here that's outlined, migraines with aura and estrogen birth control may increase risk of stroke or heart problems. This is a fact. This is aside from IVF. So migraine with aura. So this is patients who have not just migraine, but aura. So whether they see things in their, whether they have added things in their vision or numbness or tingling for brief moments during, either before or during their headaches, that's an aura. That's a phenomenon that can occur with migraine. That alone is a slight increased risk of stroke. And if the patient with migraine with aura also takes hormonal replacement therapy, namely estrogen, we know that those patients have an increased risk of stroke or heart problems. That's a fact. Um, Now, there's some caveats to that, but just at the very basics, migraine with aura plus estrogen birth control increases the risk of stroke and heart problems. Now, what we don't know is whether or not the supplemental estrogen exposure during IVF also results in stroke or heart problems for those patients with migraine with aura. And the reason we don't know that is simply because it hasn't been studied. Um, and because the exposure to estrogen in IVF isn't quite the same. Um, it's very brief. It's sometimes a few weeks and at the most 2 months. Versus if you look at patients who are getting estrogen birth control, they're getting it continuously. They're getting it for months or even years. So it's unclear if that brief exposure to estrogen in IVF leads to the same sort of vascular risk factors such as stroke or heart problems for patients with migraine with aura. So that's a question mark we have and an area of exploration and studies that really needs to be done. So another question that we have is, what effect does infertility treatment have on headache? That's the big question for this whole presentation. Um, this first statement, several studies reveal that some patients experience mild headaches from medications used during IVF. Now, when I say several studies, most of these studies are studies on this medications themselves. There really has only been one study on IVF cycle as a package itself. There has not been a whole lot of great studies on IVF itself. There have been only studies on each of the individual medications themselves. And an analysis of all these single studies on each of these medications has revealed that perhaps somewhere between 10 to about 20% of patients treated with these assisted reproductive technologies are experiencing some degree of headache. Now, here's an example of a study looking at a single medication. So, Ganirelix is a popular medication used in IVF. It's a GnRH antagonist, and it's shown that almost three-quarter of patients are experiencing mild headache. So that's somewhat helpful information. Here's another one. So buserelone is an LH medication, and goserelone is a GnRH medication. In the first 1 to 2 weeks, patients are experiencing headaches with these medications. Folotropin alpha, it's a synthetic FSH medication. Headache can occur in about 7 to 15% of patients, using this medication. Um, 3 to 20% of patients using clomiphene. This is a medication that induces ovulation by stimulating FSH and LH. So 3 to 20% of patients can experience mild headache with that medication. Um, Clomiphene can cause some other interesting phenomena aside from headache. It can cause positive visual symptoms, blurred vision, shimmering objects, flickering lights, and it can even cause a trail of after images. You can see like if you see like a trail of images throughout it called palinopsia, illustrated in this image over here. So, as I mentioned earlier, there's a there's studies of each of the individual medications used throughout IVF, but there's only one study looking at the whole cycle of IVF, and that was only a retrospective study. As clinicians, and many of you in the audience may be clinicians or researchers or just be familiar with the various different qualities of studies, you may know the term retrospective study. Retrospective study is not the highest quality of study. It's not like a randomized control study where we actually eliminate the various different types of biases that can occur with a retrospective study. So a retrospective study is not the highest quality type of study, but that's what we have when we look at the whole package of IVF. That's the only type of study we have for IVF. Um, and so there's several types of biases that can be introduced with a retrospective study, several types of limitations, but that's all we have when we look at IVF. And the study only looked at 98 patients, and only 25 of those patients had migraine. Um, and what was found from that? It found that more frequent migraine episodes did occur during IVF, especially when estrogen levels were low. And this is kind of what was theorized and what is seen during menstruation as well. Now, what are some of the limitations of that? One of those limitations is that the researchers of that study asked patients of that IVF treatment to look back on their experience 3 months ago and recall, did you have headache? Now that's difficult. Instead of, during the IVF cycle, chart down actively day by day, do you have a headache today? Do you have the headache the next day? That would be a more of an active charting of your headache experience rather than 3 months ago, do you remember having a headache? That introduces recall bias, another type of bias that's an opportunity for bias within a retrospective study. So baseline headache data also was not available. That's another limitation of this study. Aside from that study for IVF, there's some other data we can look at for IVF. So one is looking at IVF in the migraine with aura population. So just some pathophysiology here. So how does aura occur? So aura occurs from a phenomenon called cortical spreading depolarization. That's a slow wave of activity change involving brain cells that move across the brain surface, illustrated at the bottom image here. It spreads very slowly, about 3 to 6 millimeters per minute. This is the electrophysiological culprit responsible for migraine aura. Now, what are the symptoms of migraine aura? We mentioned that earlier. It can be a visual aura. It could be sensory changes, so like numbness or tingling of the arms or legs. It can be motor weakness. Here's an illustration of what a visual aura can look like. As clinicians call it scintillations, or they can be zigzag lines of various colors in the vision. Some people call it a kaleidoscope vision. So this is an illustration of a typical visual aura. So, how is that relevant here with IVF? Estrogens have a role in cortical spreading depolarization or depression. In laboratory studies, higher levels of estradiol increase sensitivity to cortical spreading depression and related pain responses. Therefore, it's plausible that either naturally occurring during ovarian stimulation or from medications used in IVF, they may contribute to triggering or worsening migraine aura in some patients using IVF. Numerous studies report an increased risk of ischemic stroke and MI in those with migraine with aura. And again, we mentioned this earlier, that steady estrogen oral contraceptive exposure may lead to ischemic stroke and MI or myocardial infarction or cardiac issues in those patients with in those patients with migraine with aura, but it's uncertain if that brief estrogen exposure in IVF treatment is going to lead to those same sort of vascular issues, such as stroke or cardiac issues in patients with migraine with aura. So that really needs to be studied. So we're exposing patients to estrogen in IVF, and we're exposing them, even those migraine aura patients, with an uncertainty whether or not there is a risk of stroke. There's another sort of vascular complication to consider, and for some of you folks who are looking into IVF, you may be familiar with this known complication of IVF called ovarian hyperstimulation syndrome. You may not know it as a vascular complication, but you may know it as a cystic enlargement of the ovaries, a condition that can be marked by abdominal pain, nausea, and vomiting, a condition that can also potentially lead to potential for ovarian torsion as well. Um, but I'm not saying that OHSS is caused by migraine or the other way around. We do not know if there's a cause and of effect. We just know that there is some sort of association of OHSS and migraine. In a study examining 111 OHSS cases and 222 controls, Migraine history was reported in 34% of those with OHSS and 12% of controls with an odds ratio of 4. So there seems to be some sort of association of OHSS and migraine. We just don't know if there's a causation here. Another thing to consider is that there's been an increasing recognition that migraine is associated with hypertensive disorders of pregnancy, including preeclampsia and eclampsia. And so to back up, preeclampsia is a condition of hypertension and increased protein in the urine of a pregnant patient. Eclampsia is a little bit more of a dangerous condition in which there may be also not just hypertension and protein in the urine, but also seizures as well in the patient. And migraine seems to be associated with these disorders. So in one study, migraine was associated with a 2.3-fold increased risk of preeclampsia. Similarly, several studies report that IVF is associated with hypertensive disorders of pregnancy. So we have migraine with increased study of preeclampsia, IVF associated with hypertensive disorders of pregnancy. Um, and in fact, IVF mothers were 4 times more likely to have preeclampsia and ischemic placental disease. What we don't know is there an additive or a super additive risk of these hypertensive disorders if you have both IVF and migraine? That remains unclear and warrants further exploration and studies. All right, so now it's time to kind of look back at some of the facts that we've discussed and come to some sort of summary here. So evidence shows that estrogens during ovarian stimulation may lower the threshold for cortical spreading depression and precipitate the incidence of aura attacks or worsen aura attacks in those with a history of migraine with aura. High-dose clomiphene, which is a medication used in IVF, may produce visual attacks. In assisted reproductive clinical trials, IVF medications produce mild headaches. However, these studies did not provide further description of the headaches or the related side effects of medications. There's a dearth of clinical studies examining headache in the migraine population exposed to IVF treatments. There was only one study that really examined the full IVF cycle in terms of headache impact, and this was a retrospective study and did not capture the change in headache frequency from baseline. In addition, those results may have been subject to recall bias. Remember, they only asked patients after the fact, how many headaches did you have? It did not actively ask for a headache diary throughout the IVF cycle. Going forward, studies may help to understand the influence of migraine subtype and look at an IVF protocol selection based on headache in the migraine population. Lastly, the migraine population may have unique vascular risk, including risk of ovarian hyperstimulation, thrombotic events, including stroke and heart disease in the case of patients with migraine with aura, hypertensive disorders of pregnancy. All of these situations have been understudied in the relation to IVF exposure and warrant further exploration and studies. There's a scarce data of making evidence-based recommendations for best practice for IVF in those with pre-existing migraine. There's also few data to assist in determining which IVF protocol might produce the best outcomes. Remember that patient I discussed with you earlier? Right now, we have very limited evidence on what's the best protocols to give for each of our patients. But the best practice at this very moment would probably be coordination between our reproductive endocrinologist and our headache specialist. Protocols with less drop-off in estrogens may be better tolerated in women with migraine. However, this too has yet to be investigated. This again is the inspiration for our talk. my own personal family. Um, this is who I'd like to have credits to. This is one of our neurology medical assistants, Zachary Elkington, our headache specialist and neuro-ophthalmologist, Dr. Kathleen Degree, Susan Bagley, our headache specialist. These are my references for today's talk. And I'd like to thank you for joining us today. And if anybody would like to ask any questions, you can take this time.